Cosmetic surgery results can vary for different patients. Every patient is a unique individual and every surgery has unique aspects. Therefore, no two surgical procedures will get the exact same results, even if patients are fairly similar and even if the procedures are performed by the same cosmetic surgeon. Liposuction is the first cosmetic procedure to change beautification surgery from open extensive excision surgery into a more atraumatic closed one. Liposuction is a surgical intervention designed to treat superficial and deep deposits of subcutaneous fat distributed in aesthetically unpleasing proportions. Liposuction removes fat that you can't seem to get rid of through diet and exercise. It also shapes, contours, these areas. In our experience, in all liposuction and liposculpture techniques, although results are immediate, however, they continue to improve for 6 months following the procedure, and the patients are counseled accordingly. The evolution of liposuction into liposculpture was facilitated by advancement in technology from the early manual devices using vacuum and blunt cannulas into energy delivery machines including laser and vaser. Introduction. Even with careful dieting and sweating it out in the gym, the fact is that few people genetically have a perfect shape. Most of us have a tendency to accumulate pockets of fat in undesirable places. In women, this is usually on the inner and outer thighs, the so-called dreaded saddlebags, or on the upper and lower abdomen. Men, on the other hand, often have spare flesh in the form of love handles, or on the chest. In today's CrossFit era, many people want to look good naked or minimally dressed. So, they watch their calories and spend lots of time at the gym, and that's great. But all the chest presses in the world can't always erase gynecomastia. A diet packed with salmon, green tea, and dark chocolate won't always make thigh cellulite disappear. That's where liposculpture comes in. Liposculpture features a variety of new liposuction techniques to safely and effectively remove fat from areas where people don't want it and deposit it where they do in order to contour and shape the body, rather than simply to reduce size. How are liposuction and liposculpture different? Think of the difference this way. Let's say there is a white wall. If the wall needs to be painted blue, any painter could do the job. If the wall is to have a beautiful mural painted across it, a skilled and inventive artist will be needed. The same idea applies when it comes to the canvas that is the human body, and what differentiates liposuction from liposculpture. History. The first attempt to remodel the body silhouette dates back to 1921, when Dr. Charles de Jarrier, a French general surgeon, wanted to improve the shape of the ankles and knees to a dancer patient. Dr. de Jarrier removed a large part of skin and soft tissue, with a broad subcutaneous dissection. The result was tragic because he removed excess tissues and the sutures were too tight. This caused necrosis and amputation and resulted in the first lawsuit in the history of plastic surgery. After that, many other attempts are followed with less tragic results, with en-bloc resection of both fat and skin to recontour outer thigh adiposity, Pitangui, 1964. Several complications such as hematoma, long-term seroma, necrosis, infections, and many post-operative body deformities burdened this technique. In 1972, the German physician Schroeder published a new less invasive technique to remove subcutaneous fat, using a uterine curette. Kesserling and Meyer, in 1976, used a large, double-blade cutting curette connected to a low-power aspirator to suck the fat, previously separated from the deep plane by scissors. In 1975, Arpad and Giorgio Fischer, father and son cosmetic surgeons, developed the modern technique of liposuction. They were the first to introduce blunt hollow cannula attached to a suction source and the crisscross suctioning technique from multiple incision sites. This blunt method allowed obtaining better and more predictable aesthetic results with much less complications. The Fisher applied their method only to outer thigh adiposity. Illas and Fournier, two Parisian surgeons, modified and popularized the Fisher's technique. In 1977, a patient of Illas asked him to remove a large lipoma without a scar. A blunt cannula technique was pioneered by Illas, who developed the first version of a wet technique with minimal blood loss and preservation of the neurovascular bundles. To make the technique less traumatic, Illas gradually developed the wet technique, based on the injection of saline solution and hyaluronidase into the fat, performing a hydrodissection before the liposuction procedure. This hydrotomy allowed preserving the neurovascular bundles and making it easier to preserve the superficial flap and removing only the deep layer. Fournier, who also worked in Paris, was initially a supporter of the dry technique, in which no fluid was injected before the procedure, considering it more precise and accurate. However, experience has led him to abandon this approach in favor of local lidocaine infiltration and eventually the tumescent technique. Lawrence Field, a Californian-based dermatological surgeon, visited and studied this evolving technique in 1977. He was probably the first American to visit France and learn the new technique of liposuction from the Italian and French pioneers. Norman Martin, an otolaryngologist, visited Illas in 1980 and began performing liposuction in Los Angeles in 1981. Rhoda Nairns, a dermatologist from New York, also visited France in 1982 to learn the techniques. The blunt cannula technique came to be the accepted liposurgical method around the world, and in 1982, the American Society of Liposuction was formed to establish a teaching program. The first live surgery workshop was held in Hollywood, California, in June 1983 under the direction of the American Society of Cosmetic Surgeons and the American Society of Liposuction Surgery. 10 dermatologists attended the course. Newman first used the term liposuction and established the American Society of Liposuction Surgery. The first articles on liposuction appeared in dermatologic literature in July 1984. In 1987, Jeffrey Klein, a Californian dermatologist, first reported on the use of large volumes of very dilute anesthesiae that allowed liposuction to be performed in larger volumes completely under local anesthesia. Klein invented a recipe consisting of 0.05% lidocaine, 1:1,000,000 epinephrine, and 10 ml sodium bicarbonate per liter of saline, which could be infused into tissue prior to liposuction. This innovation dramatically altered the future of liposuction. Klein also demonstrated that the same dosage of lidocaine diluted in a large volume of fluid allowed obtaining a good degree of anesthesia even on large areas, without evidence of systemic toxicity. He also confirmed that, with such tumescent fluid, dosage up to 35 mg of lidocaine per kilogram of body weight were safe and effective. Moreover, the presence of epinephrine produced an important vasoconstriction which greatly reduces bleeding during the procedure. Patrick Lillis, 1990, demonstrated that the Klein's tumescent technique offered significant reduction in blood loss, even in suction case of over 3 liters. He verified, also, that Klein's work demonstrating minimal plasma absorption of lidocaine when low-concentration solutions were infused. Lillis verbally reported no complications with tumescent lidocaine dosage of greater than 70 mg per kilogram. Ested et al. Proposed the maximum tumescent safe lidocaine dosage to be 55 mg per kilogram body weight. Liposuction was born as a suction technique by means of vacuum pump. However, the Brazilian Luiz Toledo, in 1988, experienced the use of disposable syringes for aspiration of adipose tissue. The main advantage was a wider freedom of movement for the operator, making surgery simpler and easier. In addition, the syringes allow surgeon to know precisely the amount of local anesthetic infiltrated and fat removed. Toledo also proposed creating a patient's body map to ensure symmetry as much as possible. Also, the amount of injected local anesthetic and fat tissue removed from each body area to be matched. The vacuum pump-assisted liposuction makes the surgical procedure more comfortable for the surgeon, especially if large amounts of fat to be removed. Therefore, the vacuum pump-assisted liposuction was usually chosen for major lipoplasty procedures, in which quantity of fat to be removed is a priority over the topographic, symmetric, precise distribution of fat harvest. Ultrasonic liposuction was introduced by Zocchi, in Italy, in 1992 as an alternative to blunt cannula suction. Zocchi credits Scuderi for the original concept of lipoexeresis. This technique is based on the application of ultrasounds to the fatty tissue to be aspirated, resulting in thermal and mechanical effects to the surrounding adipocytes. These mechanical oscillations pass through the cannula that emits the waves from its tip. The thermal effects play a role in fat dissolution and must be dissipated by tissue infiltration. Ultrasonic liposuction was embraced initially in South America and Europe and then largely rejected after experience with skin sloughs, burns, and seromas. Laser lipolysis began to spread after the publication of the studies about the interaction between laser and adipose tissue, conducted by Apfelberg and Apfelberg et al. In 1992. The action of the laser causes the rupture of the adipocyte membrane and consequent release of oily content into the extracellular fluid. In addition to the cytolytic effects on adipocytes, the laser can cause neoformations and remodeling of the collagen and reorganization of the reticular dermis. It is particularly indicated for localized areas of lipodystrophy in the body or face.